Good morning and welcome to Talking Cafe Live. Today, Friday, the 18th of December. My name is Lucy Tobias and I am one of the Homefirst community agents working in partnership with Musgrove Hospital. And I'm delighted today to be joined by Lynn, who is a strategic lead at the County Council. So I will introduce Lynn and let her tell us a little bit about what she does and what today's Talking Cafe is all about. So welcome, Lynn. Please could you sort of tell everyone your name, what you do, and a little bit about what we're going to be talking about.
Yeah, thanks, Lucy. So I'm Lynn Stephens. I'm the strategic manager at Somerset County Council with responsibility for what we call the Health Interface Service. And that is a grand title really for the hospital social work service. So that oversees all the social care services that go into the acute trusts that cover Somerset. So that it's predominantly Musgrove Park Hospital in Taunton, Yeovil District Hospital in Yeovil, but also Western General and the Royal United in Bath. So I oversee those services that are operating in those hospitals, trying to ensure people can be discharged in a timely way so they're not in hospital any longer than they need to be, and they get the most supportive and the best care for them upon discharge if needed. And I think today we're going to be talking about discharge, but also about the intermediate care model, which is the model of discharge that Somerset has now adopted. And also that was the model that was given to us at the beginning of COVID, all those months ago, in March, April time, that the Department of Health and Social Care said that the hospitals needed to adopt, systems needed to adopt a discharge to assess model. And that's what we did. So we put in an intermediate care model to discharge. And that's all, that's what I'm here to discuss today.
Thank you so much. That's really useful. So I can see that there's a few people joining us. Welcome to all those joining, watching live and on replay. So we're going to talk a little bit more in detail about the intermediate care model, which both Lynn and I work within. And this model is to support people as they leave hospital and return to the community, be that in their own home or be that in a care home for a temporary time or a longer term. So do let us know that you are here. I'm going to put the comments up on our screen so that the two of us can see. If people have any questions or want to interact with this broadcast, we are keen to do that. So Lynn, there's going to be a lot of people that perhaps watching that are out there in the community, perhaps working in the community. We have some micro providers, some community support groups that might watch, and individuals that perhaps either previously, at the moment, or in the future will have a member of their family in hospital. So for me, I think one of the key things that would be useful for us to talk about is a lot of people feel anxious when they have a member of their family in hospital, because it's a really unsettling time, particularly this year, because in the media there's so much roar about what's going to happen if you get COVID. It'll be useful to reassure people and give them some guidelines of where to contact, who the people are. And I don't mean necessarily names, but like a job title, for example, that when somebody's at home and they've got a member of their family in hospital, where they should go to know that they're talking to the right person to get the right information and to support the process. Does that sound okay?
Yeah. Shall I start by just talking through what the intermediate care model is? Yeah, great. Okay, so it's it's a big word, but intermediate care has been around for a long time. And we were actually on the road to developing this. So we'd started what we called Homefirst, which was working in Somerset, but it wasn't as wide ranging as what we've got now. And then COVID hit, and we had the guidance to tell us that you needed to implement a discharge to assess model. And so we were already going to do that, but COVID accelerated that process. So what the intermediate care model is all about, it's about not making decisions about somebody's future long-term care while they're in an acute hospital, because we know very often that is not the right place to be making those decisions. So if you're in an acute hospital, you're never going to be at your best. It's usually an acute phase, so it's a short-term phase of something that's happened to you, some sort of medical emergency has happened to you. So you're not at your best for us to be making decisions about what you're going to need long-term. So the idea is that you are giving people the opportunity to get as well as they can with support before we start talking about whether you do need long-term care. So the intermediate care model is a multi-agency model where we're all working together. So you've got adult social care working with therapists, so that's occupational therapists or physiotherapists, working with the nursing staff, working with the doctors, discharge facilitators, coming together to try and understand what the person wants, what is best for that person, and acting in their best interests. So the system is that if you find yourself, unfortunately, in hospital and you cannot go home without some sort of help, you will be assessed, a very quick assessment by a number of professionals trying to work out what is best for you. And if it's deemed that you're safe, you can go home. So that means that they feel that you could manage between visits, but you do need some support to enable you to increase your independence, possibly get back to the level of independence that you had prior to hospital. You will go home on what we call discharge to assess pathway 1. So you go home with, and you're met with by a key worker. You'll have a key worker. That's usually a therapist, but it isn't always a therapist. It could also be an adult social care worker. And you'll have a provider who will support you. You'll have an assessment over 72 hours, trying to understand what support you need to enable you to stay at home. And you'll be given that support, and that will be reviewed. And then if it's found that after that period of time, you need, they've done the best they can to get you to a level of independence. If you need ongoing care, your case is then transferred over to the locality team. They find the care for you. You'll have a worker that will work with you. The care will be put into place, and then that's it. So you're back at home with the support that you need, and that will be reviewed on an ongoing basis if to find out what any changes or any tweaks that need to be made. So that's pathway 1. We are trying to get as many people as possible home on pathway 1, because we know that people do better in their own home. People always, their outcomes are generally better, and in the vast majority of cases, that's where people want to be. We always feel better, don't we, when we're in our own home with the people that we want around us, with our own support networks, and where we're familiar with everything. So that's the main aim. So we try and get something like 75% of people that need support, we're trying to get them home on that pathway 1. Unfortunately, though, there are going to be people who've had quite a heavy medical episode that can't go back home immediately. So those people would be assessed and moved to a bedded facility. So it's a quick assessment. It's not a full-blown Care Act assessment, but the decision is made by that multidisciplinary team that actually you're going to need rehabilitation, but in a bedded facility. So unfortunately, you're not at a level that you would manage at home at the moment. You need more intensive support. So then you would be transferred over to what we call pathway 2. So pathway 2 is a shorter term intervention, but it's in a bedded facility. So in Somerset, our pathway 2 options are it can be a community hospital. For example, we've got Bridgewater Community Hospital, we've got West Mendip Community Hospital, who are both Pathway 2. We also have Pathway 2 in a care home setting. So we have Cookson's Court. So we do have Pathway 2 settings in a community hospital and in a care home. So that doesn't mean anything, though. They are the same. It's just about where we could source suitable settings, and also we need to make sure that we're covering the whole county. So that is Pathway 2, and again, once you're in Pathway 2, you're there hopefully for the shortest time possible, but you will have a team around you. So there are therapists based in those Pathway 2 facilities, as well as nursing staff and care staff. And you will have, there are adult social care staff allocated to those facilities. So once you're in there, you'll have an assessment. You'll be reviewed regularly to see how you're progressing. You should be given an estimated discharge date, which is the date the team think, yeah, you know, we can do this work with you, and hopefully, you know, with your agreement, we will be aiming to get you home by this date. So that's Pathway 2. And then we have another pathway, which is Pathway 3, which is even more intense. So that's where you really, at the moment, the likelihood of going home is not so great. It's deemed quite likely that you may need to go into longer term care. But we don't like to make that decision, as I said before, when someone is in an acute hospital. So to try and make the best decision and the fairest decision, it's again giving someone an opportunity to develop their independence. So that's what Pathway 3 does. So your expected length of stay in Pathway 3 is expected to be longer than in Pathway 2, for example. And then you'll have, again, it's Pathway 3 is all, at the moment, all our facilities are care home facilities. So we have Sherborne House, we have Oak Meadows, and we've also got some beds in Glastonbury care home. So they're all care homes. And you're there, again, you've got a therapy team around you, nursing staff, adult social care around you, supporting you, reviewing you, to try and get you home if at all possible, but it's slower stream rehab. So if we can get you home, you will go home. If not, you could move on to longer term care. But it's making those decisions with the person and their families, excuse me, if there are families involved. So that's what Pathway 3 is. And then there is another option we have, which is for people that unfortunately have mental health or quite severe cognitive deficits. So they may have dementia. And again, we don't want to make a decision in an acute hospital, but it's felt that your level of dementia means that you're not really going to benefit from a period of rehabilitation, but we want to give you an opportunity away from an acute hospital. So then we have the option of interim placements in older people's mental health homes. So you'll go there for a short period of time, again, to be assessed, to see what can possibly happen, you know, what are the options, and then you're either moved, potentially you could go home if we feel we've got the right support for you at home, or you move on to longer term care. So I think that's all the options that we have at our fingertips, but I'd like to stress that it is very much a team effort. So we have the social care involved, we have nurses, doctors, therapists. We also have the voluntary sector, as you know, so we've got the community agents and lots of other community organisations where we feel will benefit. We've got the providers, so we've got our care home providers, we've got the people who are providing care in people's home, as well as our micro providers. So it is quite a complex system underneath it all, but essentially that's what the intermediate care model is about. It's about trying to make the best decisions for people, to give them as much independence as possible, to get them back home, because we know that home generally is best for people.
Thank you. That's really wonderful and so comprehensive explanation. And that's exactly the field that I work within. So I'm called a Homefirst community agent. We haven't kind of moved forward with our titles.
No.
We do need to kind of move that along, but there are 3 of us at Musgrove, which is myself, Lucy. There's Kia and there's Russell. So we're based at Musgrove, and we work within that team. So with the occupational therapists, the social workers, the care agencies that are providing the intermediate care, and then at Yeovil District Hospital, we have Emily, Janice and Kerry Crofts. And then we have 3 agents, although one is just moving on. So the names that are working within the mental health sector and also with the community hospitals. So we have Melanie Rose, Sally, whose surname escapes me, Sally, and we are just recruiting for one more within that team. So we are a great interface between the service and the families and the individuals.
Yeah.
So
how do you get involved in those conversations? How does that happen that someone would access a community agent? At what stage?
Daily, we have a care cluster call. So each morning at 9 a.m. I join a care cluster call, and so I work within the Somerset Care and Bluebird cluster, which is based in Taunton and West Somerset. And so in that meeting are occupational therapists, social workers, rehab assistants, somebody from the care agent. So in my cluster, there's Bluebird and Somerset Care. And then each of those other agents that I mentioned their names, they also sit in on their own cluster calls. So we talk about patients that are in the discharge to assess service. And so it's really a multi-agency approach. So that we share information and support one another. So a referral might come to me. Somebody might say, a social worker or an occupational therapist, I've got such and such who's just coming into the service, and they need some support to find a private package of care. They need some support to move furniture around in their home, get somebody to help them with meals, shopping, a community solution, as well as lots of other things like utilities and benefits and you name it.
Yeah. So it's all those little things, isn't it? Because sometimes it's those little things that can become quite a big thing for someone to be able to stay at home. Totally.
And so and the pathways that you mentioned earlier, so myself and my colleagues have experience of all of those pathways. And you know, there's a client that I am supporting, her and her family at the moment, who is in a bedded facility in Wincanton, that's moved there from Musgrove, because there are some complexities that are stopping her going home, and so we are keen to sort of get her home for Christmas. Obviously, Christmas is a week today, and
I know. Gosh,
how did that happen?
Yeah,
Christmas that today or anything. But yeah, you know, and so we do work as a team, and it is you know, working, you know, and then also I do work in some of the other clusters. So I've got some clients that are in the Sedgemoor area, which is the Brunel cluster that my colleague Russell sits in on those care calls. However, sometimes referrals are shared between us, and I had a conversation close of play yesterday with the social worker in that team, because a family had been given a direct payment from social services to fund care. However, because they live in a small little village and there are many complexities to the case, the decision has now been made to go to core care.
Right.
So there is sometimes all of this batting back between.
Yeah, because I think sometimes it's felt if it's a difficult area for us to find care, that if you give someone a direct payment, that hopefully they can source a micro provider, which is a you know, a bespoke provider that very often visits a very small number of people, but you can get quite a high level of a service, and you can really get to know your micro provider very well, you know, because you may be only one or very few people that they see, and it works better in those smaller areas. But the downside to that is if there's no micro providers in that area, then it's going to be very difficult to get anybody to support you. And that's you know, that's a lot of the work has been going on as well in commissioning of adult social care, is trying to increase the level of provision we've got, so we've got more choices for people when it comes to them having to source, you know, care or have care sourced for them. Because that's what's key to keeping people at home very often, is getting the right level of care in their home that they get on with, you know, because having someone coming into your home it's quite an intrusive thing. So you've got to get that right. It's not always that easy. Especially now we've got COVID, so you've got all the other, you know, PPE and all of that to contend with. And that's one of the pressures we've got at the moment in all the hospitals, of course, is the level of COVID positive people we have in there. So that's making things quite a challenge to manage to meet people's level of need. But then if they're COVID positive, there's issues around, well, you know, you can't just discharge somebody back, for example, into a care home if they are COVID positive. So it's all a bit challenging at the moment. But that's what we're here for, and it's challenging for everybody, isn't it? And, you know, it's been a very challenging year all around. Can I just take a moment to talk about another piece of work that we're working on within the HIS in Musgrove and Yeovil predominantly, and that is at the front door. So we've got social care this winter in the front door, trying to turn people around, because what we often get is you'll get someone who's not managing, or it's perceived they're not managing very well. There'll be a phone call to the GP, for example, and the GP may then phone the ambulance and say, I'm really worried about this person, can you go out? The ambulance go out and they'll see somebody. They're a bit worried, they're not quite sure what to do, so they will convey that person. So they'll take that person to hospital. But very often, well, on many occasions, the person doesn't actually need an admission. They need something, but it's not something that they're going to get in an acute hospital. What we're trying to do is prevent them being admitted, because once you get an older person being admitted to hospital, lots of things can go wrong. So if they're in a bed for a large part of the day, they have muscle wastage. They're also more likely to fall if they're out of bed, because they're in an unfamiliar environment. And also they're highly likely to pick up infections. Even before we had COVID, you know, we knew that was a risk of hospital acquired infections. So it's not good. We're trying to, and also we need to be keeping the limited acute bed capacity we have for people that really need acute care, you know, the really sick people. So we've invested to put people in the front door who are working with their NHS colleagues already in the front door to try and turn them around. And we've seen some great successes here, because what we're able to do is instantly know that we've got someone that's pitched up that, for example, has had a fall at home. So they've come in, they've been examined, there's no, they haven't broken anything, they don't need any acute care. And we're then able to refer them on to a service called Rapid Response, for example, who can then go and take that person home and manage that person over a few days, trying to ascertain what support they need. And maybe they don't need any support, but Rapid Response is there as a supportive agency to go in, monitor them, and to say, well, yeah, actually, you could manage, you're fine now. And that they then pull out. Or it could be, yeah, we've done our work, we've assessed you, and you do need ongoing care, and then they can be referred on to ongoing care. They could have D2A, pathway 1. But it's about trying to avoid that person having a prolonged stay in an acute hospital they didn't need. And what's really exciting about this work as well is we are now getting so much information from it that we're being able to link to the ambulance service. So we can we're trying to stop the actual journey to the hospital happening, because if the ambulance service could connect direct to Rapid Response, then we'd stop the journey, the unnecessary journey that person has to experience, because I don't think it's very comfortable or very pleasant having to be conveyed to hospital, but also having to save in the ambulance time and the ambulance staff. So that's quite an exciting piece as well, that we're working on in those at the front door space of the hospital. So that's not just A&E. When we talk about the front door space, we're also talking about the frailty unit. So a frailty unit is someone that if you are deemed to have a frailty, and that there's a medical assessment behind that I don't fully understand, but you've been deemed to be frail, you would be moved quite quickly into the frailty unit, and you're there for a set period of time, and then they'll do an assessment to see whether, you know, what you need. So we're also going into that space to try and turn those people around to get them home. So that's really quite exciting, that one of the things that we're doing at the moment. So it's all linked together, as you can see, you know, trying to build in intermediate care, building in the diversion work to try and keep, fundamentally, I mean, Homefirst sums it up, doesn't it? It's keeping people at home, getting them home. Homefirst is best, you know, but also it's freeing up the NHS facilities so that we can manage the, you know, that level of demand that we have for people that really do need acute care.
That's wonderful, and we will be joining that service, the community agents, and discussions are in place at the moment. So
that's right. Excellent.
Look forward to supporting and helping to stop those hospital admissions, because as you say, you know, pretty much everyone, given the choice, would prefer to be in their home environment.
Absolutely. Especially now, because you go into hospital, no one can visit you. So, you know, if you go into hospital, at least in the old days, you know, you could still have contact with family members, even though it wasn't very nice. You're in a very sterile environment, you know, you can only come in certain times, and then it's always a bit difficult. But now, you know, you can't visit. So when someone goes into a hospital, they really are very, very isolated.
Totally. And I think it's so key to have that wonderful team of support that are continuously reviewing the patient and the client, and interacting with the family, seeing what possibilities there are, so that they've got options if that's open to them, and so that the correct decision about their care and their ongoing needs are given.
Yeah,
that's great. That's really, really useful. So I'm not sure if there's anyone that's got any questions. I don't think we have. Nobody's put too many comments in the box, so that's great. And I think that's really, really useful, Lynn. I'm not. Were there other things that you wanted to discuss, or are we kind of like coming near to a close?
I can't really think of any more things we can discuss. You know, we do have, I suppose, the other elements. When I talked very much from a hospital point of view, because at the moment that's my field. But we also have another strategic manager that's in the community. So that's Emily Fulbrook. So Emily is responsible for all the services that are going on in the community, and we're very closely linked. So, and we're also doing a lot of work around the neighbourhood. So we're linking to have multi-agency teams in neighbourhoods. So you talked about the clusters. So that what we're trying to get away from is the idea of somebody has a hospital admission, and then they sort of go on to another team, and there's no join up. So we're trying to make that much more streamlined, so that person's journey is held better, and the information is streamlined, so that although the individuals involved will change, that there's a better sharing of communication, a better understanding of that person's position. And what we're also doing with the front door is that we're noticing patterns now, and you'll get certain people who you see more often than you probably would expect. And we're trying to see behind that, and what is it that's causing these people to turn up or to call the ambulance on a regular basis, linking with their neighbourhood. Have they got a community social worker? Trying to enhance those links so we can wrap around care, or wrap something around that person. And that's where the community agents come in, is, you know, what is it we can be giving that person in the community that means that they aren't lonely, or they don't feel stressed on a Friday night, for example, and feel they have to call the out of hours doctors or the ambulance service. So, you know, so I just wanted to reassure people that, you know, it is linked, although for management purposes, we have separate strategic managers. We're trying really hard to get that as a linked service to support people. Oh, excuse me.
That's great. That's really useful. And you've prompted me to ask about something, actually. So a key thing that myself and my colleagues come up against is when we are supporting families or individuals that have been admitted to hospital. Sometimes before they've been admitted to hospital, they have had a core package of care with social services. If they are in hospital for a week or more, that core package of care ceases, and everything has to start all over again. So obviously that means that there's not a continuity of care, and sometimes huge disruption for vulnerable people. So for us, that's another challenge that comes forth, and it would be really useful if we could, not necessarily in this meeting, I'm just sharing that it, giving you something.
You know, that's fine. I mean, can I just respond to that, Lucy, because we've got some exciting news about that as well, because as part of the diversion work, what we recognised is that some people will go to A&E and obviously they will need an admission. Some people, we can't divert everybody. Somebody does go that needs admission, but we don't want to lose them. And what we've done in the past is just what you've described, is people have been admitted, suddenly they're on a ward, we might not necessarily know they're there, and they may have had a care package, and before we know it, it's been ceased because they're 7 days. We get involved at day 13 and suddenly we've got to start again. So what we're doing in the diversion work is we are tracking everyone that has an admission, and we are finding out, do they have a care plan, a care package already? Do we think there are factors that is going to make this a particularly complex discharge? So that could be there's a bit of a housing issue, family dynamics, something like that, that we think, oh, hang on a minute, we're a bit worried about this. This could be problems. We are noting all of that information so that when the person's on the ward, the social care staff know that they're almost flagged, so they can be having the discussion with the ward staff. So in the example you've just given me, let's pretend Mrs. Smith, Mrs. Bloggs. Okay. Mrs. Bloggs has turned up, and I can see here that she has already got a care package, and I can see here that this is going to end on Tuesday. So that social care worker should be talking to the ward and finding out, do we think Mrs. Bloggs can be gone home before Tuesday? Because if not, we'll lose the care package. And they may say, well, I don't think so. I think she's going to need a couple more days. So the social worker can then talk to the care provider to say, look, Mrs. Bloggs, I know it's 7 days, but if you can just keep the care package for 2 more, she's going to go home. We've not really had those conversations before. So it's bringing flexibility. But I mean, there's going to be cases where if Mrs. Bloggs can't go home within 2 days, it's going to be like 2 weeks. Unfortunately, that care package would have to go because they've got other people to pick up. But we want to capture those people. I mean, we've already had examples of people, unfortunately, that discharged on day 7 or day 8, and we've lost the care package because we weren't in quick enough. And that's what we want to try and address.
That sounds wonderful, and you've definitely lifted some weight off my shoulders, and I'm sure we did only start this at the beginning of November, and it's been it's been fascinating, but we're learning a lot as we go. That's wonderful, and that's it, isn't it? It's just about reviewing and creating a new service that is much more dynamic and meeting the needs of clients, working in a multi-agency way so that everyone benefits, because all of us want to support individuals. That's why we all do the job we do. So that's really great news. And as you say, that new system supporting somebody where there's like just that they're just on the edge of like day 7 or day 8 for it to go and then to be started all over. It's such so many people. So that's wonderful, and I'm really pleased to hear that. Thank you.
Good.
Okay, well, that sounds like so comprehensive and so much information, which is really useful. And I look forward to sharing this with colleagues and members of the public. So it sounds like there's so much support being put in place. Well, you mentioned it briefly, and I'm not sure whether we do want to talk about this or we don't, but I'm going to give you the option, because obviously we are in what could be called COVID times, and there will be people watching that have members of family that either have had COVID or may contract it coming forward, and it would be useful for people to understand a little bit about, if you're happy to talk about this and you know what the options are for those people.
If they're in hospital with COVID, do you mean?
Yes. So obviously, say somebody, like, let's say, you know, Christmas is coming, you know, somebody might have COVID. And experience, so let's say it's an older, vulnerable person, because both of us work in services which support those people. So obviously they contract COVID, and the symptoms are significant as such. They call the doctor that perhaps says, you know, maybe you need to go to hospital. So then what can perhaps be the journey for that person? Or, you know, maybe they stay in hospital, they have some support, they're better after a week or 2 weeks. Then what's happened? Do they just go home? Or, you know, because people don't really know. And you might not be able to talk about that. So if not, but
yeah, no, I think, well, it's definitely very much on an individual basis, isn't it? I mean, everybody should have a test before they're discharged from hospital. So you can't discharge someone, for example, we can't discharge someone from hospital who's positive into a care home. But I believe you can be discharged home, but then it's about risk management. So it's about, if you're going home and you're going to have care coming in, it's about the care provider. So is the care provider going to be able to pick this up, full PPE, etc., etc.? Or is it that actually, because what's happening at the moment, a lot of the hospital wards are closed or restricted because of COVID positive people. So they're not actually moving anywhere. So, I mean, that's a very sad situation where obviously people are going to be in a hospital setting until they get a negative test result. But it is very much, I think, on an individual basis, really, depending on how severe things are and when they test back as negative. But it is a really difficult situation. I mean, winter is always difficult because we have the pressure of people in the hospital. Usually we have flu. Usually you have an element of neurovirus, you know, the sickness and diarrhea bug. And then this year, on top of that, we've got COVID. So I don't think, you know, for a lot of people, Christmas is just not going to be anything like the Christmas that we're used to, unfortunately. I think we've got to hold on to the hope that next Christmas will be different, and hopefully, you know, back to the normal Christmas that we used to. But I was reading something today somewhere about, you know, someone's having a very disrupted Christmas. They can't see it's a grandmother who can't see her grandchild, recently born grandchild, so she hasn't seen it yet, but they've decided they can't travel because now their family's in a tier 3 area. But, you know, she said, you know, it's one day of the year, you know, and hopefully they'll come through it, they'll be well, and they can celebrate us another time next year. But it is going to be that I can't, you know, pretend things are going to be easy, because I know they're not, and they're going to be very difficult for a lot of people, for people who are in hospital over Christmas. If they got COVID, I think it's unlikely that any of those will be going home, unfortunately. But, you know, if they get better, they will be home next year.
That's great, and that's it. And I think the key words that I've just taken out of what you said a moment ago is that it is reviewed on an individual basis, and how wonderful people have that personalized support, because that's so key. What's right for one person is not for another. You know, even to me, what's right for you is different to what's right for me. That really gives hope for those watching and those people that are in hospital.
Yeah, I mean, we do a lot of work to try and you know, to take into account individuals. For example, we tend to do we have a fair number of couples, you know, that end up in hospital together. And we do go above and beyond to try and maintain couples staying together. And that can mean, you know, working with care providers if they have to go into interim placements. How can we make this work that the couple can be together? If they have to, can they isolate? So some care providers can provide isolation. You know, you can have a room where you're isolated from other people, so you can be isolated for 7 days or 14 days, whatever you need. But we do try, you know, very much to meet the needs of the individuals involved and try and take account into any of those, you know, circumstances and characteristics. And it's really important that, you know, we try and do that, particularly for, you know, if people have been together for a long time, we try our best to keep them together.
Totally. And there are people that have been together longer than I
Yeah.
or you in a life. The couple actually that I mentioned before, or the client that I mentioned before, that I did, you know, that somebody that I'm working with in Sedgemoor, that is a couple, and they both want to stay together at home.
Yeah.
And you know, of course, how distressing if they've been together for 50 years or something, you know, and then one of them it gets sick. You know, people want that reassurance, and that's, again, wonderfully reassuring to hear you say that. So
yeah, and they must be reassured because, you know, the law and the guidance backs them up. You know, we've got the ethical framework that talks about, you know, you are going to have to take into account what that person wishes. If you're making a difficult decision about someone that lacks mental capacity, you have to be reasonable. You have to try and engage them as much as you can. And under the mental capacity law as well, you've got to be trying to make that decision that you know that person would want, not enforcing a decision on them.
Exactly, and that's what all of us will, you know, work towards, those pieces of legislation and the morality of that as well.
Yeah, that's what we would want, isn't it?
Yes,
you know,
exactly.
That is what I would want as I sit here now. You know, I'd want a decision that's taken that is my decision, or as close as it can be to the decision that people that know me best would know I would want it to be.
Exactly, and I had that exact discussion with 2 family members recently for a client that I'm supporting that said, oh, I don't think she's got capacity, she's got dementia. And I said, the thing is, if the worker, the occupational therapist, said that they do have capacity, and then the decision has to go to the individual.
Absolutely.
And sometimes I'll challenge that, but yeah, they don't understand that every person, and when they're in that situation 30 years down the line or whatever, their wishes have to be paramount.
Absolutely.
Capacity.
It amazes me that, you know, you wouldn't even think about someone that's 40, for example. You wouldn't even think about overriding
but
that.
Only for 10 days. In 10 days.
Well, congratulations.
And I will become 40. I will be 41.
But yeah, so you'd never dream of suddenly telling a 40-year-old what you're going to do. But as soon as someone gets a certain age, at 80, it's like, right. So some people think you can start to tell them what to do. I don't really understand.
It's not right, is it? Thank goodness we have legislation that supports people to have their own wishes, and those to be supported. So that's great, and I think what a wonderful place to end on, that all of us are working to support individuals in hospital, in the community, and in that interim process. And it sounds absolutely wonderful, all of these new changes, which both you and I are working within. The future looks bright, doesn't it?
Yeah.
So thank you so much.
Thank you.
We're sort of at a wrap. We wish you a wonderful Christmas, and potentially we'll have you back again if there's something you wish to share. Okay.
No problem. It's been a pleasure, Lucy. Thank you very much.
And likewise, Lynn, it has been a real pleasure, and we've even had some laughs. So
yes, and I hope people have learned something or benefited from it.
There will be people, and I will be sharing this video afterwards. So those people that maybe are joining near the end of the video, please go back and do have a watch, because there's been lots of really useful information shared by Lynn through this video. And those watching on the replay, do stick any comments, feedback in the comments box, and as soon as we get to them, we will, and every comment will have a response. So yeah, thanks so much.
Thank you.
Bye everyone. Bye, Lynn.
Bye.
Bye.
Bye.